Hello, everyone. Welcome to this talk. Thank you for the opportunity to present you this work in this nice workshop. And I'm sorry to being pre-recorded. I would have loved to have you in front of me and to be in person, but I guess this is the reality of the 2021. But nonetheless, I'm Christophe Gaudet-Blavignac, and I'm working at Geneva University Hospitals, and I will present you the work we've made, in fact, in the SPHN project around knowledge graphs in hospitals, and a talk that I named the many challenges of semantic interoperability, because you will see that this is kind of the main challenge in this work. So as I said, I work in Geneva University Hospitals, which is a hospital that is in Geneva and that is usually very glad to compete with CHUV, so it's a positive competition, of course. It's a pretty big hospital. It covers 8 hospitals, 2 clinics. In 1 year, we have around 56,000 inpatient stays, 4,000 births, 1 million ambulatory consultations, around 300,000 patients by year, and 12,000 workers, which is quite a big structure. Not very big compared to other places, but for Switzerland, it's quite big. And in such a big structures, interoperability is a real challenge. And just to be kind of easy to explain, to try to simplify the concept, what is interoperability? In fact, interoperability is what happens when you call someone in Japan. It's easy to take your phone, to connect to an antenna that will connect to a satellite that will go to another antenna in Japan, and to have someone's phone ring in Japan. And if someone answers, you can say hi, and they will maybe understand you if you speak the same language. All the necessary steps for your hello to get into the head of someone in Japan is interoperability. And in fact, in a hospital, those needs, those interoperability needs are everywhere. If you are in a hospital, you will have a lot of people, a lot of jobs, more than 180 jobs in HUG, if I remember correctly. So all those persons, the pharmacists, the clinicians, the nurses, the genetician, the laboratory expert, but also all the logistics of the hospital, the guy who are cooking, the patients, of course, they all need to share information and to communicate in order to produce what the hospital wants to produce, which is care usually. So for each of those interactions, you need interoperability. You need to understand each other. And it's all the same, even more difficult when you go to another hospitals, in which you will have to understand the data and what happened is in these new hospitals. And this is a challenge in healthcare since a long time. In fact, there is a lot of research around interoperability in healthcare, and usually scientific people delimitate this problem into various layers of interoperability. And if we look at multiple definitions from different authors, we can delineate 3 main categories of interoperability. First, the technical interoperability, which is around the pipes, in fact, the phone that you take to call in Japan, how it connects to the satellite and to the phone in Japan. It's technical interoperability. It's around the piping from you to the person you want to talk with. Then there is a layer on which kind of everyone is agreeing on the name, which is the semantic interoperability, which will be what interests us today. Then there is the process interoperability, how the people harmonize in what they work, in how they work, but we will not get into that today. In fact, semantic interoperability is the way to understand each other. It's about the meaning of what you want to share. And it's very easy to understand that when you have a language, any language such as English, French, but also all the technical language that are used in a hospital, you need semantic interoperability because it's easy to misunderstand each other. And if you talk about a simple concept in medicine, which is shock, a patient that is in shock, it will be very different in the mind of the clinician and in the mind of the patient, depending on his background. And they can understand a lot of things about the simple concept of shock, which is some vital sign for a clinician, but maybe for the patient, it will be electrical shock, emotional shock, or all other type of shock. So even if the pipe are working, the technical interoperability, it does not bring the semantic interoperability, which is why I will speak a bit of that today. To try to tackle this problem, the problem that data is not, the meaning of data is not easily shareable because we all speak different languages, we all understand things differently. Usually in healthcare, we use semantic standards. And I'm sure there is such standard for neurosciences and for proteins and for a lot of stuff in the neuroscience, but in healthcare, we have a lot of standards. It's very common. You have the International Classification of Disease, which add a code for each disease. You have the CHOP classification, which is a Swiss classification for the intervention, surgical interventions. But you can also use LUNG for laboratory values. You can also use ICNP for nursing procedure, or NANDA, which is another nurse classification, ICPC for primary care, etc., etc., etc. And each of those classifications is a way of compartmenting knowledge, of representing some knowledge in a stable way, because you add a code to it, and you say, okay, this is pneumonia. It's the code G13 in the classification of disease. So I just store, or I take G13, and I don't have to care about what do you understand when I say pneumonia. You just have to look in the classification. I give you the code, and I externalize the meaning. And this is very good. So it should be no problem, right? But in fact, a few years ago, last year, in fact, we all lived something kind of weird, which is the reason also why I'm pre-recording this presentation and not presenting in front of you. Almost 2 years ago, we feel that we didn't moved a lot since that time. But in March 2020, everyone in Switzerland had to go home because there was a pandemic. And the pandemic hit the whole world. Of course, you know that I will not speak of COVID too much today because we hear all the time about it. But in Switzerland, we had the similar patterns as in other countries with two first wave and then a few other waves. And now the revival of November 2020 with a new fifth wave that we are all bored of, and we don't want to see that anymore. But what this pandemic teach us is that, in fact, we are still not very good with using data in healthcare. There is still a lot of problem, and this was seen in a lot of places, that the reuse of healthcare data to count the cases, to know how many people died, to know who had COVID and who had not, was a real challenge. And there was problems in a lot of countries, and even in Switzerland, of course, where we struggled to get the data correctly. And in fact, this showed that semantic interoperability, the way of representing the meaning of the data, is still a challenge today. And why that? A few reasons. First, when you look into a hospital and you look into an electronic health record, you have multiple types of data. It's not like in some field where it's all signal data, like in different scientific domains, where you have one signals on, you deal with images or you deal with sounds, and that's all. In an electronic health record, you have everything. You have text, you have categorical data, you have numbers, you have dates, you have a lot of things. You have signals with ECG. You can have quick notes written quickly. Then all that in a hospital is stored in a lot of places, different databases connected to each other. It's very complicated. Nobody has a global knowledge of the system. And when you want to work with it, it's very difficult. So that's a challenge that is still there, because the hospital is a big functioning machine, and you cannot say, okay, we stop everything and I want to work with the data. You have to work while the machine is still running. So the second problem is that there is too many languages, too many of those semantic standards, because everyone wants to use the classification they are used to. For billing, you use ICD. For nurses, you use NANDA or ICMP. And for pharmacists, they use ATC codes for drugs. But in the logistic of the hospital, it will be maybe GTIN code. And you have a lot of language to speak about a lot of things. And it's like being in a room where everyone is speaking their language and nobody understands each other. And that's also a problem. Then you have also too many codes. If you look at in SIMDIS, you have 16,000 codes, in CHOP 18,000, in ATC 6,000, etc., etc. It's more than enough, and it's very difficult to handle those huge classifications all at the same time. In fact, if you look into the American US version of ICD-10, which is ICD-10-CM, you even have a code to represent the fact that you have been struck by a turtle, and it's the second time you meet a doctor for it. And seriously, I thought a lot, but I only see one person that would be subject to using such code, and I don't think he's the most representative of the Americans. So you have a lot of codes to say a lot of things, and it's very hard to handle those big classifications. Lastly, we have to keep in mind that when we encode information, we kind of damages the data. That's inevitable. If you want to express something with a classification, you cannot keep the full information that you have. You have to put codes on it, so you will lose something. And I often take this example, but if you took a scene of the real world, or more the Disney world, but still, and then you try to represent it with words, with sentences like Snow White asleep surrounded by the morning dwarves, and then you want to encode that with ICD-10, it will be not very representative of the real situation. You will have a code for coma, you will have a code for intoxication with arsenic, you will have a weird code for the dwarfs, for short stature due to endocrine disorder, because you don't know much more about it. And you will have a code to say that they are sad, but it will be something weird like other problems related to primary support group, including family circumstances, which is a kind of exclusion code which you put when you don't know what to put. So you lose information when you encode. So you have to always keep that in mind. So what could we do for that? Since it's very important when you are in a hospital to reuse the data. You want to, of course, use the data for care, which is the primary use of data, but you want to be able to reuse it for a lot of purposes. The first one being the billing, because you have to bill those inpatient stays, but also for public health. In a pandemic, it's very important for a hospital to be able to say, okay, I have X COVID patient currently in the hospital, I have X patient that died of COVID, etc., etc. So for public health, and of course, in the end, for research, because you want to be able to do research. Since we store a lot of data about patients, it would be very sad to not be able to do research on it. For that, there was in 2017, in a time where we were not on Zooms, there was a national initiative which was launched. It was called Swiss Personalized Health Network, and it was an initiative around building an infrastructure to enable nationwide use and exchange of health data for research. So really what I was explaining. So the idea was to say, okay, this initiative, this big federal initiative, will lay the ground for the ability of Switzerland to reuse healthcare data of a lot of its hospitals for research in a federated way, like you do research on multiple hospitals at one time. This was an initiative which was very ambitious, which included 5 university hospitals, which was launched in 2017 with a quite big budget for Switzerland, 137 million. And in this initiative, I've got the huge chance, the huge luck to be part of a working group, which was the Clinical Data Semantic Interoperability Working Group, or CSI for the people who know us. And it was a group chaired by my professor, Professor Christian Levis, which had the goal of advising on clinical data interoperability standards, data formats, and exchange formalism to be adopted with SPHN, because SPHN had the need for a semantic, an interoperability strategy. And the goal of this working group was to create this. And in fact, the output of this working group was explained in a paper recently, which was published not so long ago. A paper that explained in a scientific journal, but the strategy was also already published and implemented in this SPHN. A paper that explained the strategy and what we call the 3 pillars strategy. The idea was to say that, in fact, the beginning of everything is the semantic. We have to enforce that all the data shared in the SPHN is strongly bound to some semantic standard. The preference of this strategy was to use SNOMED-CT because it's a huge ontology that I will not get into it today because it takes a long time to explain, but an ontology that can represent most healthcare concepts, but without being mandatory about it, but just saying there is one semantic standard that we prefer. If you have to use another one, you can, but what is mandatory is to use one. You cannot just share your data without the semantic layer. So the first pillar of the strategy was to say a strong semantic is needed for your data. The second was to say that we don't want to choose a data model. And this is a choice that we made because if you choose a data model, there exist common data models for healthcare, but what we know is that they are all targeted to a purpose and they are all not fit for everything. So if we choose one, we will lose some people and we will complicate the situation for some hospitals or some goals. So the idea was to say that for the data, to store the data and to share the data, we use formal descriptive languages. In fact, the choice was made to first use the RDF, which is a data format, the resource description framework, which is a descriptive language that you can use to describe kind of everything and tie it to link it to a semantic. And with this neutral data storage layer, which is in fact a graph, RDF is a format to describe graphs. So nodes link to another node by an edge, by a link, which we call a predicate in RDF. So a subject, a predicate, and an object. Once you have those data stored in those graphs, you can convert them to any data models that you need. And if someone for a study needs to have his data structured in OMOP, which is a common data model used in research, or in CDIS, which is a standard used in pharmacology, or other data models, you can create a bridge between this neutral storage to those data models, and then you only have to build one bridge, and then you can store your data and output it in those various data models. So this was the 3 pillar strategy. So first pillar, a framework with a set of concepts that are strongly tied to semantic. The decision was made to first use the concept that would be used in a project to list those concepts in a data set, but focusing first on what would be used, and to extend it as a use case by use cases. The second pillar, a common approach for storage and transport, no a priori definition of a data model, use of descriptive formalisms, and the choice of formalism depending on the use case, but the first one was chosen was RDF. And the third pillar with ad hoc conversion from descriptive formalism to the second to the second pillar data to ad hoc data models, and to build reusable bridge to do that. So this provoked the need for a way of validating those new concepts that would be used in the SPHN. So the validation process was structured as followed, with first the research project that would propose a new concept that they need in their research, with the data coordination center that validates those requests, put it in a data set that is validated by the National Steering Board and then endorsed. So the research project can use it, give it to the hospitals, get the data from the hospitals, and do their project. So the data set was made and published. In fact, at first, it was done simply in an Excel with the concept and the mapping. You can see the mapping in SNOMED, the mapping in LOINC, which were two semantics used at first. And those data sets were published, used in projects. And currently, they are, the group moved to an ontology, which they publish on their website, which is a GitLab. So you can download, you can even consult this ontology online in an instance of Web Protégé. And this ontology is the SPHN. SPHN ontology, it contains the necessary codes, the necessary mappings, and can be used for research project, which is very, very nice. And we have currently a lot of driver projects, which were the first project of the SPHN that use those resources and this three-pillar strategy. And currently a new wave of project national data streams that are still complying to this strategy. So this whole project was kind of, it became the national standard for sharing of healthcare data, getting all the flexibility of RDF and knowledge graphs at the service of healthcare research, which was very, very nice. So now the SPHN vision with this strategy could go into action. So you could have a feasibility study directly on the nodes that are put at the availability of researcher to see if you have patients for your research, then make a data agreement with the hospitals that are focused on your project, which have the patient that you want, then get the ethic approval, do the registration of the project on the system, and get the data transfer. The hospitals can then encrypt and copy the relevant, the identified and consented, of course, data to the Biomed IT node, and the researcher can perform the data analysis on those data. Thank you very much for hearing me, and I will end with a citation from Alice in Wonderland, because it's a book in which there is a strong emphasis on semantics and the meaning of the language, and the idea is that the Hatter's remark seemed to have no sort of meaning in it, and yet it was certainly English. So it's not because you have the language that you have the meaning. Thank you very much.